Everyone, and welcome to our Global Health Rounds. Dominic Alain, I know several of you. I'm the director for Global Health, and thanks for joining. Today, it's my great pleasure to introduce Dr. Kevin Lobe as our speaker. Dr. Lobe received his bachelor from the U of A, his Doctor of Dental Medicine from UBC, and his MD degree from the University of Calgary. He completed his general practice dentistry residency, hospital dentistry in 2006, and his FRCPC, which is the Royal College of Physicians and Surgeons of Canada, finishing his emergency medicine residency program in 2011. And both of these degrees were through the U of A. And then he topped off these dental medical degrees with an MBA, very impressive, from the Alberta School of Business, again here at the U of A in 2017. He's been an associate clinical professor here at the U of A for 9 years now, and he's also been very active as a transport physician with STARS Air Ambulance for 11 years now. He's also been the medical director for EMS, Provincial Air Ambulance, and the intra-facility strategy since 2019. And he's been working hard as an emergency physician at the U of A hospital here with the AHS for the past 10 years. So as an emerge physician and a dentist, he's completed many international volunteer missions over the years. And Kevin hopes that you'll find this to be an inspiring conversation that will raise important questions regarding our role as healthcare providers and global citizens in general. So Dr. Lobe, the floor is yours.
Thanks, Dominic. Appreciate that introduction. It was very nice. So welcome, everyone. And thank you for taking some time to tune in today and listen to the Global Health Rounds today. And I hope you'll find this to be an interesting conversation and discussion where you'll hopefully learn a little bit of something about what's going on in our world and also specific to the dentistry care that's happening around the world, and maybe gain some insight and perspective that you may not have you might not have had an appreciation for before. So without further ado, I'll just proceed here and with the presentation. So as Dominic mentioned, I have training both in dentistry and medicine, and I work primarily now as an emergency physician, but I also have some involvement still with the dentistry school. And over the years, I've gone on many trips internationally as a dentist, doing volunteer work with a variety of different organizations. So, and as Dominic mentioned, I also work with our provincial air ambulance program now as well. So I don't have any conflict of interest in this presentation. It's, I don't receive any funding, quite to the contrary. I pay a great deal of money to go on these trips and volunteer. And these views and perspectives that I'll share are my own. They don't represent that of the university or anything. Maybe they do, but they certainly aren't intended to in this case. They're my own views. And the images that I'll share are just taken by myself, generally with consent of the people that had their photos taken. And I also wanted to acknowledge that the University of Alberta is situated on Treaty 6 territory, traditional lands of First Nations and Métis people. And I wanted to acknowledge that partly because, in fact, most of the parts of the world that I travel to, and I wanted to remind myself to mention that virtually all of these locations where we're going to are primarily Indigenous peoples in those communities where they're where we're helping to improve their dental care. So as I share pictures from around the world, most of these communities are Indigenous communities. Now, for many years, Alberta-based dental charities have played an important role in serving communities all over the world. And I hope to provide an overview of Albertans and Canadians' charitable contributions and lead up to a bit of a discussion of the current state of affairs with what's happening and maybe suggest some considerations for how we can move forward. So I hope you'll find this to be an inspiring conversation that will raise some important questions around, what are our roles as healthcare providers? What should we be doing? Do we have an ethical and moral role to support care around the world? There are a number of dental charities in Alberta. These are a few of them, probably the largest of them. But there are others as well that some of them are simply individual dental, clinics that go and do volunteer work every year. But the ones that I've been involved with, or that I have some knowledge of, are listed here: Kindness in Action, which I've done most of my trips with, which was started by a dentist who lives in St. Paul, a fellow named Emil Shapka, who was actually a physician and dentist as well. And he decided that he would start doing some international work, and built an organization now that's been able to, that has volunteers come from all over the place, all over Canada and the United States, and participate. And primarily the Albertans who contribute their time and travel with this organization. On a given year, they might do 8 different trips to different parts of the world, for example, with 8 different teams, and quite a lot of logistics going on in the background to support those teams, which I'll talk a little bit about. Another is the Society for Third World Dental Care, also called Dentistry for All, which the first trip I ever did was with this organization, led mostly by a fellow named Dr. Dennis Bedard, and he's a pediatric dentist, and was instrumental in collaboration with funding from Lions Club and other organizations, putting together this Society for Third World Dental Care. Change for Children, another major organization that partnered with Kindness in Action and also has some of their own dental work that they've been doing. Canadian Humanitarian as well, which is largely Alberta-based, and which I have not worked with, but I have some friends that have. So these are all grassroots organizations that have sort of developed through efforts of charitable Albertans who wanted to contribute and work and help internationally, and they've grown from there. And just so you kind of understand the process of how these organizations work, well, they raise money from lotteries, from just charitable contributions, from donations from dentists and families and others who are interested in helping. And they raise money. These organizations connect with different communities around the world, with charitable. So it's a connection between dental charities and charities that are happening in communities all over the world. Some of them have connections with their local churches, some of them don't. And for the most part, they're not particularly church-based organizations. None of the ones I listed they have connections often with church communities, but they're not necessarily directly linked. So they're separate from they're secular largely. So they connect with organizations. Teams are built up. They assemble supplies. They bring their supplies with them as checked baggage on commercial airlines. So you usually have a suitcase of your own and a bin filled with equipment. And you bring it with you to various different parts of the world with your team. Usually the team meets for the first time at the airport. When they're there, everyone's gathering to get on the plane. Some teams, they're coming from Toronto, Calgary, Vancouver, all parts of different Canada. Even in the United States, sometimes we have some people come up. And so sometimes our teams meet, for example, in Houston at the airport. The whole team is kind of there before we get on the plane to go down to Guatemala. But these teams assemble, they're planned in advance, the trips are booked, and the groups move together and often haven't met each other until they arrive at the destination or in transit to the destination. And then there's, as you can imagine, a great deal of logistics, which I'll talk about, getting that equipment and people to communities, to setting up their equipment in the communities, and to delivering dental care. So the team, these are dentists and physicians. Sometimes they're both dental and medical organizations combined. Sometimes, but for the most part, the ones I'm discussing are primarily dental. We have dental hygienists, dental assistants. We have often registered nurses, lay people who come to help. Translators are very important in many of the communities where we go to, and that's often provided by people in those communities, who can speak some English and who help out. Local community leaders, as I mentioned, are really important. Usually it's our charity, the dental charity, that's connecting with the community leaders in these different places, whether they're women's health organizations or just a whole range of different charitable organizations in these communities that we connect with and that help with the planning. And sometimes it's community leaders. Sometimes the local mayor would, is involved. In one trip I went to in the Philippines, the local mayor was really fundamental and their city council was very helpful as our main contact. And we have obviously cooks and drivers and mechanics and others who contribute once we arrive. So I've just shared a few pictures of some of my teams here. And one of the images I wanted to show you here, for example, the image of the team on the left there with the Coca-Cola sign. We've got some dental students there who've come from the University of Alberta. We have a variety of others in the background as well. Some people who have from the United States with the medical volunteer organizations that we connect with there in Guatemala. And of course, Coca-Cola is there represented in the image because many of the communities where we go to, one of the factors in the dental health problems that they experience is related to refined carbohydrates and sugars in their diet that have been introduced to the communities and that and result in dental caries, especially in kids. So that's an important consideration as well. And so I've just shared a few pictures from Ecuador in the bottom right, and then Guatemala there in the center with the blue shirts. So, and Guatemala as well as the image there with the Coca-Cola. So getting there. So as I mentioned, we usually meet at the airport. We have our supplies assembled in bins that have been put together by the charitable organization we're working with. The bins contain all the equipment we need. And we transport that equipment down to where we're going. And so commercial airlines are always involved. Sometimes smaller airplanes to get from an international airport in Guatemala up to a different part of Guatemala, for example. Buses of all sizes, from the smallest little vans to big buses sometimes for our group to travel in. Hopefully air conditioned, but not always, because sometimes if we're in a particularly hot part of the world, it can be pretty uncomfortable for the long commutes that it takes to get to where we're going. Taxis, local cars, rickshaws, and tuk-tuks even sometimes to get around the communities. This was one of the most interesting boats that we went on, I think, in the Philippines, where I've shared a picture here to get out to one of the islands where we were working. And then ferries as well to move our vehicles across rivers or lakes. And then here a nice image of a truck helping to take some of our supplies to one of the communities. And you can see some of our bins there in the back of that truck, as well as a bunch of green plastic chairs that we'll be using to sit on when we're working in the clinic. And you can see some of the roads that we're traveling on can be a little bit rough. And this would have been probably in Uganda, I believe, in that image. So the communities we serve, and generally speaking, these are, we often will base, our teams will be based in smaller communities, but communities that are big enough still to have hotels or accommodations where we can stay. And then we'll usually go out from those small communities. Either we'll set up clinics in those small communities where there's enough of a size of to have a hotel or something. And then we'll branch out during the day sometimes to really small communities, to really remote communities up in the hills or whatnot. So some of these images are from the towns where we're staying or the cities where we travel through. And some of the images that I'll share are from the very small remote communities as well. And so images from Peru and Ecuador, Uganda, and Cambodia there. In some cases, we work in Nicaragua. I can think of one, there's a municipal dump there where one of the trips I went on, we did some work at the municipal dump. So we actually stayed in Managua and we would go to a small school right beside the city dump there. And we did some work on kids who literally live in the dump with their families and have no significant access to dental care, even though they're in the middle of a major metropolitan city. Their access is limited by finances. So we would go and do some work and support those schools and communities as well. So there are, I kind of mentioned briefly that there are drivers or predictors of poor dental health. And some of those can be just access to refined sugars. Sometimes it's not Coca-Cola. Sometimes they're chewing on the sugar cane. That's what's causing the dental health. And and so, you know, there's various predictors, but certainly refined sugars in the diet would be the number one cause of cavities, obviously, right? There's often poor awareness of dental hygiene. There may be cultural factors that predict poor outcomes, such as extracting. One of our participants in the meeting, this discussion today, mentioned before we started that she had in one of the communities where we worked in Uganda, they had a tradition of pulling out certain teeth just at a certain age of development. So that created all kinds of orthodontic challenges as the child got bigger and their adult teeth came in. And so there can be cultural challenges as well that can create barriers to good dental health. And access, certainly financial access, logistical access. In many cases, the country had problems, you know, civil wars or whatnot, which resulted in disruption of education of dentists, or the universities that couldn't support education for dentists. And so in some cases, these communities ended up with just insufficient number of dentists to support the people. Like in Guatemala, for example. Peru is starting to catch up. They have quite a lot of dentists now in Peru. But in some parts of the world, like Guatemala, there's still very limited access to dentists. And that usually was created by conflict in the countries where we've traveled to. Cambodia, another good example. And so there are various predictors to poor health, dental health in those communities. So clinic locations, as I mentioned, they're usually in small communities. Sometimes we'll set up in intermediate size or large cities, but generally the work we're doing is in very rural locations. So we're having to travel a long ways to get even to the place we're staying, and then several hour drive out in the morning to get to these communities where we're setting up our clinics, for example. And so often we try to work in areas where there are schools, and many of these communities have, probably because of the influence of the Catholic Church in different parts of the world, where they had set up churches and schools. So there's an infrastructure there where these children are based, where they're getting their primary education. But in that same little area, like right across the field, is the local church, and they could be various types of churches: Protestant churches, Catholic churches. You know, the benefit of that location is that we have a roof over our head, whether it's the church or the school. We have desks and chairs that we can use, and we also have lots of patients, because you have usually a lot of children in those communities that need access to care. And so you've got the kids in the school, and you've got the infrastructure that you need to set up a clinic, a functioning clinic. And so often we would find ourselves in these communities parking our supplies and our trucks and unloading into these school rooms or churches sometimes. And occasional local health clinics we would use as well, occasional local health clinics. What we need, well, we need road access to where we're going. We need ideally electricity. We don't always have electricity, and we'll talk about that. A roof over our head, like I mentioned, is really good, whether it's pouring rain or it's just so hot from the sun. You need that protection from the elements. We need some tables that we use as basically as the dental chair, so the patient lays on the table often. We need some chairs to sit on so that we can do our work, or we stand. If the table's high enough that we can do dental procedures while standing, then that's fine. And we need patience. So that's what I've illustrated in these images, is the different, most of our patients in these brigades that we do, these trips that we do, they're largely pediatric patients. So it's mostly, very large part of this is pediatric dentistry. We need local support. So I've illustrated in that image there with the fellow with the pink shirt on. He's a local dentist in one of the communities where we've worked in Guatemala. And in the top right image there, a translator in Peru who was very helpful in helping We had the support also in that top right of the patient's dog, who was laid on the child's chest in order to keep him calm during the procedure. So that dog played a vital role in supporting that patient and our treatments. We usually hire local cooks and chefs to help prepare meals for us during the day. And so and often those meals are prepared over open fire stoves in very traditional manners, because that's what they have access to. And in fact, the food is incredible often. So we're very fortunate to have that. So local foods, local produce, local cooks, and local people, local traditional foods we largely eat, and we're very obviously very much appreciative to our cooks and chefs every day that support our eating. So I've listed a few of the participants or local supporters here on the left that help us with our trips and to keep us fed and housed and so forth. So we bring a big team of people, but we rely on locals as well to help us and support our needs. So as patients arrive in the morning, usually there's been a lot of advertisement before we arrive, sometimes on the local radio. Sometimes we even have participants go on the local radio who've come with our teams to help advertise and inform. We have these huge waiting rooms that people come in the morning and they've lined up, and they set up in hopefully an area with some shade where they can await their treatment. And so I've included a few pictures of people in our waiting rooms over the years. And you can see here, in this picture on the lower left, it says, "In God we trust." And often that just shows you, and then the Holy Family Catholic Parish one in the middle, it shows you the facilities we're using often have a church base to them, or church support or community support. Which is really important in the infrastructure of what we need. Triage. So the patients line up. Often they're waiting initially in the waiting room, and then they get triaged, and then they might be put into a secondary waiting room to await the specific treatments that they need. Triage is often just an assessment to determine what needs to happen. So we have a look in the mouth and we say, okay, you just need a cleaning, you need fillings, you need some extractions, and then that person could then be triaged to the appropriate waiting area, sort of an internal waiting room for whether they need hygiene done or they need extractions or fillings. And we do, as I'll show here on the next image, all kinds of dental treatments. Really, the clinic environment, the clinic setup is pretty rudimentary in terms of our chairs and our tables, but the equipment we're using, the gauze, the gloves, the masks, the eye protection, everything is up to the standards that we would have here in Canada if we were getting dental work done. The equipment is sterilized. The supplies are sterile gauze or sterile syringe tips, needles. Everything is to the same standard. The care that's provided is to the same standard as you would expect here in Canada. And the care is provided by licensed, trained dentists, dental hygienists, people that are qualified to practice. And so that's very important in the organizations that I've worked with, is that these are qualified practitioners doing work and providing the care to the standard of care that you would expect here in Canada. So, and these are often experts, they are subspecialists even in pediatric dentistry or oral and maxillofacial surgery, largely general dentists that are practicing. And our volunteers, our dental assistants, are a very important part of the team, because the dental assistants help us set up the equipment. They know how to mix the amalgam and the composite. They know how to get everything ready to go, how to ensure that the dentists are supported in the care when they're providing the care. We bring equipment that is, they are portable dental drill systems. And so they have suction, they have a low speed and a high speed handpiece. They are designed for military application by, MASH units. So they're portable dental drill systems. they run off of compressed air. So we need an air compressor. And in order to drive that air compressor, we usually have a generator. And so we either bring a diesel generator to power our compressors, or in some cases, there's enough reliable electricity in the community where we're working where we can just plug in our compressors into the local power. So as you'll see, I'll talk about that a little bit more. But another factor here you can see in one of the images is a lot of fans, fans, because it's hot in some of these clinic environments. So having a fan in front of you is the best, because then you don't get so overheated. And you need to drink a lot of water in some of these communities too. You're working longer hours in very hot conditions. And with a fan, you sweat a lot. And so a big priority for us often, if we're working in very hot climates, is to stay cool and stay hydrated. So I also included a couple images here with me and my dad. So my dad is in a few of the images here in the blue scrub top. He is a plastic surgeon in Edmonton, and he came along and was a dental assistant for us on our trip to Ecuador a few years ago. So he's included here as well in some images. So equipment, as I mentioned, I've got a few pictures here just to illustrate the type of equipment we're using. In the picture in the largest picture on the left there with me working, wearing my scrub top, in the background, you can see the dental drill system, and it's got a little, they call it a 3-way syringe tip. That's a little air and water blower machine, device. And then you've got a couple of, there'll be a suction on the far right, and then a couple of drill systems. So this is the type of system. And there's a large hose that you can see that helps with the suction system. There's containers beneath it, one container that contains sterile water and one container that collects the suction. And then that is powered by compressed air. And air compressors are very important. And I haven't shown any of our air compressors in these images, but we do often bring ideally we can rent an air compressor in the community where we go, or the local, the local supply store will have an air compressor that we can rent. And sometimes we rely on local generators. So that image there of that apparatus, that's a generator, that's a diesel generator. So that's a power generator, because in that particular community, we just didn't have adequate power. So we needed a generator to power our compressors, to power our drills. And then I also have shown some pressure pots that are on a stove, and pressure pots are used for steam sterilization of our equipment. So we wash our equipment off with special chemicals and that provide some level of sterility. And then we go through a process where we sterilize the forceps and other dental equipment that we would potentially reuse. Much of it is disposed of, but the stuff that's reused, we would pressure pot sterilize it after the cold sterilization, where you wash the equipment. You then pressure pot sterilize it, and then you have to take it out and let the instruments cool down until you can use them. And so the instruments are laid out on that table on the right there. You can see a number of our forceps and various different devices used to extract teeth are laid out there. And that's a very typical clinic setup that you can see there on the lower right, with some tables and chairs. We use garbage bags with duct tape to kind of cover the surfaces over. We often will bring little pillows, or we'll create little pillows for people to use for their heads, with basically the pillowcase being a garbage bag that's sealed off so it can be wiped down after use. And so you can kind of see the environment. You can see some fans there on the wall, and you can get a sense of how we kind of walk into these schools and we go, okay, how are we going to turn this into a clinic? And then over the course of about 45 minutes to an hour in the morning, we turn that care space into a clinic that we can use. And so then the patients come in and we work on them, and then we can select, as you see, the equipment's been laid out there after it's been sterilized. And sometimes we're going through equipment so quickly, we literally have to wait until the dental forceps are cool enough that we can physically hold them with our hands so that we can go and start using them on a patient that's waiting, because sometimes we're really cycling through a lot of patients and who need procedures done. And sometimes after our equipment has gone through the steam sterilizer, it's very hot. So you have to wait till it cools down enough to use it. So sometimes it's, you're just waiting for it to be, so it's not so hot that you can actually start using it and use it for the next patient. So just kind of gives you a sense of some of our equipment and supplies that we have there. In the foreground, in that lower right image, you can see some yellow and blue. Those are our sterile needle syringe tips that are used. Obviously, we use sterile needles, of course, and they're disposed of after every use, obviously. So, and I don't think I might not have shown, but I had an image of some children in one of the other images with a bunch of clear plastic water bottles, and clear plastic water bottles are often used as our sharps bins. So we, because of course we're going through a lot of water sometimes, and we often bring our own water containers, but we'll have some water bottles as well that we use as disposable sharps containers. And now, what are the risks? Speaking of sharps, and being in an environment where you're in a clinic environment where there's needles and sharp things, there are some inherent risks to us as practitioners when we go into these communities. And certainly when you look at the local ambulance here in Kabale, Uganda, you can see that the health clinic supports, should we get sick, should there be a problem, so should one of our health practitioners roll an ankle and sprain their ankle or have some medical problem, when you're going to these very remote parts of the world, you often do put yourself in some inherent risk in being there. So there's that, because the health resources are limited. There's some risks to us in terms of endemic health. If you're going to Guatemala or something, you can often expect that you're going to have a bit of an upset stomach after a few days if you're eating the local salads and so forth and exposing yourself to stuff that your stomach's not used to. So foodborne illness is common. Traveler's diarrhea, not that uncommon. When we were in Uganda, certainly there's a very high prevalence of HIV/AIDS in the community where we were. Scabies is another one that I encountered in one of the communities I was in Guatemala a number of years ago, and ended up with a little rash on my neck, which I quickly treated easily. But you're exposing yourself to these risks when you're in these communities, for sure. Poor roads and infrastructure. There's risks of, flat tires or having problems with mechanical breakdown. There's the health regulations. When you go into these places, usually every country's different. And so as a health organization, as a charitable organization, you try to connect with local governments, you get the appropriate permits to go into those countries. But in some cases, those countries don't really have a process for approving and giving permits to people who are coming in. Or if they do, they might not really follow them. And so a number of years, about a year ago, one of the organizations I mentioned, Canadian Humanitarian, ran into a problem in Ethiopia, for example, where a group got arrested and was put in jail for a few days. And, so that obviously is not good. And fortunately, everyone did well and returned safely to Canada. But when you're going into environments where, we have dental licenses and so forth here in Edmonton, in Canada, but I don't have a Guatemala dental license, for example. So what are the health regulations? What are their local rules and regulations around people coming in from other parts of the world to work there? And sometimes those are a little sketchy or a little unclear. And that's just the reality. And that ties into the problems that they're having with their healthcare infrastructure in the first place. And their health policies and their health infrastructure isn't great to begin with often. And that's why, and similar to that, their policies and around other people coming to work there are also not that robust. The work is physically demanding. By the time you're done a week, you're sore, your back hurts, your neck is sore. And if you run into a problem in looking after a patient, say you're having trouble taking out a tooth, in Edmonton, you just phone up your local oral and maxillofacial surgeon and say, hey, I can't get this tooth out. Can you help out? And we'll send them over to their clinic. But when you're in Uganda, you rely on your team. And fortunately, we always have a very, very good, competent group of dentists that are staying within their scope of practice and that are very competent. And so I don't believe that I'm aware of ever run into any issues where we can't manage the patient within our scope. If we do have a patient which is beyond our scope, we recognize that right away, and we would say, listen, I'm sorry, I can't do this work. And I would, we try to facilitate referrals to local experts in those communities. So, and then there's benefits though. I mean, in spite of those risks in working and traveling and helping these people abroad, we have many benefits in the work that we're doing. So this shows you just an image of part of one of the teams I was recently traveling with in Peru. And, this is deeply satisfying work. It's very rewarding to help those in need. And the community and people and the patients are very appreciative. Some children are not that appreciative because they're crying, but the vast majority are very much happy and appreciative of the work that we're doing. This is an adventure for anyone who goes on these trips, and you build new friendships. You have valuable life experiences that impact your perspectives on the world and on what our role in it is. And there are tremendous opportunities for teaching. The dentistry students, several of the people here in this image are dental students from the University of Alberta Dental School from, I believe they just recently graduated, I believe. And, this is an incredible opportunity for learning for our students. You just don't do as many extractions. You don't really learn the type of dentistry in the dental clinic school environment. You don't get the same level of experience and volumes and opportunity to learn as you do in these environments. So incredible opportunities for teaching, as myself as a clinician and other dentists, and then incredible opportunities for learning for our students. So I kind of wanted to, give that as a broad overview of what we do and the work we do, but I also wanted to get you thinking, and I'm sure this isn't unique to this particular topic in global health rounds, but where do we go from here? What is the future? What should we be doing at the level of the university or beyond to support these sorts of efforts? Should these efforts continue to be run and coordinated at the level of small local charities? I can tell you the amount of logistical work that goes on in the background is overwhelming. The amount of work that has to go into this to make these trips happen really by volunteers is just so substantial. It's almost overwhelming. And so are there opportunities for a broader, more coordinated effort? Should our university offer support beyond the support of having their students come out and help us and learn with us? Are there opportunities for the Faculty of Medicine to coordinate some of these things? Should the university offer support, or should it be a government type initiative? Should this be a national initiative to help broaden the ability for Canadians to help other communities abroad? And so, I kind of wanted to open it up to you as an audience, if anyone has any thoughts, or perhaps just wants to email me or offer their thoughts, or perhaps I'm sure there's some real experts in global health here on in the call that might have some comments on that. So really that's all I had to share with you today. And I was hoping to inspire some conversation and discussion. So if anyone has any thoughts to share, please do.